Hello viewers, today we shall discuss the laser treatment of retinal breaks. First we shall see those breaks that do not need to be lasered. Asymptomatic retinal tears, asymptomatic operculated holes and asymptomatic atrophic round holes. Asymptomatic horseshoe tears. Only 5% of asymptomatic horseshoe tears progress to retinal detachment, and so there is no evidence of, if there is no evidence of a subclinical retinal detachment, then a follow-up alone is enough. Those breaks that definitely must be treated are symptomatic operculated holes and atrophic round holes, symptomatic horseshoe and fresh horseshoe tears, acute symptomatic retinal dialysis, traumatic retinal breaks, tears near the vitreous base, history of rhegmatogenous retinal detachment in the fellow eye, presence of vitreous traction on the margin of the break or operculum, presence of vitreous or pre-retinal hemorrhage with a break. There are conditions where there are no clear-cut guidelines, but many people do treat. In asymptomatic horseshoes associated with high myopia, with lattice degeneration prior to cataract surgery, aphakia and pseudophakia, where there's a strong family history of retinal detachment, in physically active and sports persons, especially contact sports. Some evidence suggests prophylactic treatment of asymptomatic retinal tears be considered prior to YAG laser posterior capsulotomy in high-risk eyes with axial myopia. The purpose of laser treatment is to create firm chorioretinal adhesions around the break in order to prevent access of fluid vitreous to the subretinal space, thus preventing a neurosensory detachment. For retinal laser photocoagulation, green laser, either in the form of argon green or frequency doubled YAG laser, is the predominant type of laser used, as it has excellent absorption by melanin and hemoglobin with relatively poor absorption by xanthophylls, thus sparing potential macular damage. Diode laser may also be used. Laser may either be delivered via the slit lamp or by laser indirect. Slit lamp delivery allows a magnified view and more precise delivery and is useful in clear media. Laser indirect is useful in hazy media for long treatments because of positioning and in very anteriorly located breaks. After obtaining written informed consent and ensuring maximum pupillary dilatation, a topical anesthetic is instilled. However, a peribulbar or a subtenons may be administered if the patient has nystagmus, is uncooperative, or cannot tolerate the discomfort. Coming to laser parameters, spot sizes of 200 to 500 microns are considered the standard for laser retinopexy in the peripheral retina. These are applied for 0.1 to 0.2 seconds at a power that ensures grey to moderately white burns, usually in the range of 200 to 400 milliwatts. It is to be remembered here that less energy is required for smaller spot sizes and longer durations of application. Now, coming to the actual lasering. The anterior margin of the break is photocoagulated first, as this part is more difficult to visualize and the patient may cooperate better during the earlier stage of the laser session. An initial single row of spots with an interval of 1/4 spot size is given. A total of 2 to 3 nearly confluent rows must be placed around the break. Treatment of peripheral horseshoe tear should be extended to the ora serrata if the tear cannot be surrounded using laser. The most common cause of failure in treating horseshoe tears is failure to adequately treat the tear, particularly at the anterior border. Treatment of dialysis must extend over the entire length of the dialysis, reaching the ora serrata beyond each horn or end of the dialysis. The laser beam should avoid the pathway of vitreous attachment to the operculum. The operculum of the horseshoe tear should not be photocoagulated. Recommendations for the timing of re-evaluation in the absence of additional symptoms are as follows. At 1 to 2 weeks, evidence of pigment must be looked for. Indirect ophthalmoscopy and scleral depression at 2 to 6 weeks will determine the adequacy of the chorioretinal scar, especially around the anterior border of the tear. At any post-operative visit, additional treatments should be considered if subretinal fluid has accumulated beyond the edge of treatment. A proportion of patients develop new breaks during long-term follow-up or after cataract surgery. So even if treated, patients should undergo long-term follow-up. So that's it for today. If you like what you saw, subscribe to my channel and hit the bell icon to never miss an update from AP's Ophthalmology Pulse. You may watch my other videos by clicking on the thumbnails. Please leave a note in the comment section if you wish for any particular topic to be covered in future. Look forward to regular updates. Thank you for watching.